All right, 5, 4, 3, 2, 1. What's up, everyone? Welcome to Simulation. I'm your host, Alan Sakyan. On Simulation, we bring on different global leaders that are building important futures, and we distill and disseminate all of their complex future that they're building to you in relatable and fun ways. So today, we're featuring Marquesa Finch.
Hello. Hello.
Thanks for coming on to the show.
Thanks for having me.
Appreciate it. So Marquesa is all about inclusive health.
Yes, inclusive health, wellness, something that we coined public health tech that I'll get into. Also a little blockchain on the side, but very excited about the space, especially the blockchain health space.
I love how you were just like a little blockchain on the side.
A little sprinkle of blockchain on the side.
It's like a spice that you add to the dish, yeah. Okay, yeah, because blockchain is really important in health, and we're going to talk about that, and we're going to talk about equitable health, inclusive health. So you ended up doing a master's in public health.
I did.
At George Washington University.
I did. I was on the med school track, I think like most people interested in biology or health or science, and was actually, on the pathway towards medical school for a very long time, through college and even after college. My first job out of college was working as
You have a camera right here, by the way.
Oh,
yeah, you have one right here too. Just a heads up.
So yeah, after college, I ended up working at UCSF as a clinical research assistant because I really wanted to get into kind of like the academic and research side of medicine and what that life looked like, the academic practitioner, because I was very serious about practicing medicine and I was very passionate about health. But you can't expect life to go the way it is, and sometimes life gives you little nuggets of opportunity, little windows of opportunity, and I always walk through them. That's my kind of motto in life, because you never know what's going to be on the other side. If you don't like it, you can always come back.
So you wanted to make health more applicable to people's lives as quickly as possible.
I did. And I still love the idea of treating, healing, but I realized I could do that differently than what medicine or traditional medicine was doing. And that really is treating groups, communities, populations. And that to me was just really fascinating because it was a different way of looking at health, one that we don't do a lot of in the US.
Or even just like in general, we don't look at the social fabric in different pockets of demographics because we're so very convinced that individualization of everything is the most important thing. But when we think about the social fabric in little pockets of demographics that are low SES, that we can actually be like, hey, what different types of ways can we augment the fabric in that area to help the group in that area and therefore help the individuals in that area?
Absolutely. And I think we know this, but we don't execute it well, and that's everything in life is integrated. And so other countries kind of have taken that practice or that concept and put it into practice much better than we have. I think we know that, and we're slowly getting there. But we still have a lot more work to do. And so
harder with 320 million people than with 5 million people.
It absolutely is. We are also a younger country than most other countries. And we're also not a homogeneous country like other countries, right?
Oh yeah.
So we're dealing with a lot of history, we're dealing with a lot of chasms and issues and inequities built in through that historic fabric. So it's a lot of unlearning and undoing in order to move towards the future. So it's hard. It's not easy.
I like how your mindset is like, I can do the doctor route and I can do the one-on-one healthcare route, and that's really important, and there's a lot of people doing that, and that's crucial. But then there's also the 10,000-foot view of the public health ecosystem and how we can impact people on a grander scale in that sense, and it's good to have your mind in that sector impacting people.
I appreciate it. No, it's a fascinating space, and I think the more people dig into what that means, and of course we'll go over what public health is and what social determinants are, which are a big part of public health.
Let's do that right now. Social determinants, public health, let's do it.
Yeah, sure. So the social determinants of health, which is what my fund focuses on is really about the social, cultural, and political aspects or barriers or factors, however you want to call it, that go into affecting your health. And so, traditional medicine, and I say traditional medicine because medicine is now starting to incorporate more social determinants into treatment and practice. Traditional medicine really looks at the body. So how do we treat the body as a container, right? So when you go to your doctor, they're really trying to get you back to a homeostatic level that for your body, right? A certain temperature, a certain heart rate, right? But what public health does is that it looks at the environment of which that container lives in, which have a lot of impact on your health.
Totally.
Right? So if you're homeless, chances are you're going to be
Sick.
less healthy, you're going to be sicker, you don't have access to services, you don't have access to nutrition, a house.
Malnourished, yeah.
Right. So financial health is really important when it comes to health. So is education. The more you know about how things work, the more you can avoid certain foods, certain behaviors. The more you can practice other healthy behaviors like, having more fruits and vegetables in your diet and not smoking, et cetera. Or looking both ways before you cross the street. That's someone taught you that, right? Your mother or your caregiver, when you were a kid, taught you to look left and right before you cross the street. That's a public health, a public safety, educational nugget.
And there's a couple of these nuggets that are not communicated that well to people. And so what are some other cool nuggets that we don't even that we should be thinking more about or even teaching kids about regarding their public health?
Yeah. One thing that a lot of people don't associate with direct impact to health, and when I say direct impact to health, I mean the chances of you actually getting the flu, the chances of how quickly do you recover when you're sick, how often are you sick, what types of diseases are you getting, really direct, tangible things, right? Systematic racism or systematic inequities built into our social systems have direct effects on how healthy you are, so have direct effects on how often you get the flu, how quickly you recover from illness. These direct, tangible things have really strong correlations in public health studies to things like systematic racism or poverty or low education. I mean, very, very strong correlation.
Absolutely.
And so, we have to think about, those are two points that are really hard to connect for a lot of people. And so let's talk about systematic racism and health, right? Why would experiencing racism or some other type of prejudice, doesn't have to be racism, right?
It could be classism.
It could be classism is a huge thing in this country and around the world. It could be any type of prejudice, right? There is a response in the body called fight or flight, is what we all know, right? So it's a rush of hormones, it's a rush of hormones in the body that gets you ready to either fight, it's some sort of attacker or some sort of hazard that you're being faced with, right? So something or someone is attacking you, your body goes into fight or flight mode, and you are either ready to fight or to run. So this is a very carnal, right?
Sympathetic nervous system.
Exactly. This is a very carnal response in lots of animals, right? Not just us. And so cortisol is the hormone that's released in order to prep your body for that, right? Now, when you experience little micro traumas every single day for years on end, you're essentially having a certain level of cortisol flowing through your body, an elevated level of cortisol flowing through your body all the time, right? And cortisol can have really damaging effects when that cortisol is being washed over organs and throughout other places in your body over and over again for long periods of time. It actually can degenerate a lot of tissues. It has other negative effects. And so when you're talking about how strong is the body to defend itself from disease or to heal itself from disease, well, if you already have a compromised container, then you can imagine how hard it would be to keep yourself healthy or to get yourself better if you are sick. and to maintain health, right? So that's one social determinant that a lot of people don't think about when they think about total health. And I would say the social, cultural, and political, and I say political because policy has a lot to do with how healthy we are. That's about 80% of total health, meaning that 80% of the choices that you make, the conditions you live in, the policies in which we live under is 80%. That's 80% of how well we can keep ourselves healthy. The other 20% are like access to services, right? Seeing your doctor, taking your medication.
You have a really good graphic, actually.
I do.
For this, yeah.
I do. We can pull it up.
Let's take a look at it, because I think it's good to have a visual for it.
Sure.
All right, so where were we? We were right. Did I pick?
Yeah, so if we,
it's a little further.
Let's see, if we go, let's go, I wonder if I have one on social determinants, actually.
It wasn't the other one that I think that I had open.
It might have been. It might not be in this one. But we can go back.
Because that last one was good too, yeah.
There might be this word graph that has...
Oh man, I only work with professionals.
Yeah, because we had it, that's all
Just
good.
kidding, go ahead. Just playing.
Yeah.
So I think maybe we can...
Do up and down arrow
Oh, up and
instead.
down, okay. Okay, so here, this is a good graphic, actually.
Yeah.
So these are really good examples. I forget what this type of graph is called. It's a word graph?
Word graph, yeah.
That is what it's called, right? And so when in a word graph, the way data points are represented are obviously with words, but the size of the word, it conveys the impact of that certain data point, right? So these are all the things that make up social determinants of health. I'll say at least most of them, not everything. Yeah. But you can see, like, what are some of the biggest words up there? Social justice.
Yeah,
right?
poverty, ethnicity, disparities.
Right. Health services is a big one, obviously, but poverty, race disparities, ethnicity, health policy, health promotion, right? This goes to education, health promotion. How educated are we about the things that affect health and how we can protect ourselves? Community health, what are some of the small ones? Sexuality, what is that? Developmental origins of disease. So like, how diseases develop. Cancer is pretty small on there, which is surprising. So genetics is the smallest.
Looking at
smallest.
Looking at this, thanks, Ron.
Sorry.
It's all good. Looking at this, it makes me really, one thing that we talk about a lot on the show is the importance of nuance and understanding all of the variables that go into difficult conversations, because we don't like to keep things binary. Healthcare should be this way or that way, 1 or 0, done. No, like, look at all of the different variables that go into
determining health. Because it's easy to charge that way under our fee-for-service system, right? Which we'll get into later. But you're right, it's not binary at all. It's everything relates to one another in very nuanced and dynamic ways. And I think this is why we are still learning about health, and this is why everyone says health is so complicated. It's so complicated because in between each one of these factors are a million different dynamic points that we're still trying to figure out.
Yep.
Right? But it's not impossible. I think where we can make a lot of headway is in really thinking about these social determinants of health, because we haven't in the past when it comes to health care.
I think something important to mention here is that in the US, in heavily white areas, there are social injustices that occur to people that are not white. And the same things applied in other parts of the US and other parts of the world where white people are a minority. where white people are the ones that have the issues of racism, as in there's racism happening to white people where they're not getting the best access to health care as well because of the different, all these different determinants of health.
Absolutely.
Yeah.
Absolutely. And I think that's a misconception too in the US. I only say in the US, right? And I can't speak for any other country. I'm not an expert in other countries, but in the US, by volume, most people in poverty are Caucasian. By volume. It's a misconception that people of color make up the majority of people in poverty, but it's not. If you look at the sheer numbers, it's Caucasian citizens.
Is poverty less than 1,000 a month or something?
You know what? They changed the federal poverty level recently, and so I'm not exactly quite sure what it is, but it's at or below the federal poverty level is what we define as poverty. Extreme poverty would be like 50%, 50% below, or whatever the
average
below the federal poverty level.
Oh, it's extreme.
Extreme.
And it's also interesting across the world just how 1,000 a month here can get you a lavish lifestyle in another place. It's just very interesting. Like dynamic for economies. So social determinants. So this has a lot to do with multivariability and just how do we actually build a better social fabric, which is a lot of what we talk about on the show. And so now you had been mentioning there was another word that you used with public health. What was the other word that you used?
So public health tech, maybe.
And then you had another one. I forgot. It was earlier.
No worries. So what we do social
determinants was the other one, which was what we just looked at.
That's social determinants of health.
That's what we just looked at. Okay.
So the social factors that go into health. Public health tech, on the other hand, is a term that my partner and I coined. As far as we know, and please, if there's anyone out there in the interwebs, if anyone else came up with this beforehand, or if anyone else is working in this, dear God, please get in touch with us, because it's very lonely being the only one out here.
Lonely.
Very lonely. I'm Marquesa at p2health.co. Please email me. So public health tech is essentially, the definition that we came up with is a tech or tech-enabled service that's either preventing the onset of disease, so preventative health, or addressing the needs of, we put medically, vulnerable populations. Sometimes for investors who aren't familiar with the space, we have to say medically vulnerable populations, but we're talking about vulnerable populations. And what does this mean? It means that we're building solutions, tech solutions, to support the 99% is really what it means. There is an entire market out there. Now I'm going to switch to the business side. Not only are building solutions for the 99% just a good thing socially, right? But it's a huge business case. So when you're building diverse products and services for diverse populations, there's actually evidence that shows that you not only build better products, so just, better made, but that your revenues are higher. There's a Deloitte study on this, on diverse teams, and the revenues that they've generated.
Interesting. This is something that I was looking for like 4 months ago when I was hosting Jordan Peterson, is that diverse teams produce higher revenues.
They absolutely do, and better products.
Yeah, well, I understand the better products because the better products is like if you're trying to make a product for a diverse population, if there's only one group of people making the product, it's not going to be as good of a product.
Right.
That one seems a little more obvious, but then the increase in revenue is really interesting. I'd love to see that Deloitte study and pass that along to.
I would be happy to send it to you. It's a very famous study. It's been around for a number of years. I can't even say it's new. Like, it's been around for years. I first learned about the study and other studies around diversity and inclusion when I was at the Capeware Center for Social Impact, and they do amazing work on diversity and inclusion in tech, why we should have it, how we can get there, and sort of the methods that we can employ to do it.
I don't think they're horrible words like a lot of people make them out to be.
Diversity and inclusion?
Yeah.
It's absolutely not.
Yeah, but I also think the opposite is also true of like being so pro diversity inclusion that we don't hire people based on a meritocracy is also not as good either.
Right. There's a misconception that considering diversity and inclusion means you're sacrificing meritocracy. That's a myth. That's completely a myth. And so there are a number of companies that have sprung up in that area, that are doing hiring, that are doing product development, that are taking out little pieces that could cause unconscious bias in order to produce better meritocracy, right? So hiring blindly, meaning identifiers are blind, right?
Yeah, exactly. Only the work experience is visible.
Or if it's a tech position, then only your code speaks for itself, right?
Yeah. And then this was also with I thought the symphony hiring was really interesting. They just put a barrier up and you couldn't see. You could just hear the music.
Exactly.
And I thought that was a really interesting
I think
study.
that is the inspiration for a lot of D&I products and services now on the market for tech.
And all of a sudden now you're seeing that actually there is a greater amount of people of different group identity being hired because there is a barrier now between it's a closed it's a blind hiring process.
It is. And I think these teams are actually finding that they can build much faster and much more efficient. I think they're finding that their products and services are more relatable to their client base or to their consumer base, and now they're experiencing better returns. And so this is something that we not only see in the market, have evidence for, but it's definitely something that we push when it comes to inclusive health and when it comes to public health tech, preventative health, population health, social determinants. Because this is an area that is just ripe for innovation, for entrepreneurs, for investors, for payers, for anyone that manages, employs, or deals with large populations in this area are wanting, needing, asking for solutions to help manage them.
And this is both for vulnerable populations as well as for just the overall 99%.
Absolutely. And low income is vulnerable. That's a vulnerable population.
Totally. Yeah.
Yeah, that's a vulnerable population. Anyone that is managing a chronic disease is a vulnerable population. Obviously, children are a vulnerable population. This is a much, much bigger market than the San Francisco market you and I are used to, right? Tech has been innovating for itself over and over and over again. We need to start expanding the people that we innovate for. It's a business opportunity. It's a business. It makes business sense.
It's an interesting way to put it. So it's like the people at the absolute top of the socioeconomic status, which are a lot of the engineers and designers that live here, are then innovating a lot for the top 1 or 5%. Yeah. And so if their attention can be aligned with good incentives in like public health tech and other areas, then all of a sudden we can maybe get a lot more innovation for these other 99% of people, especially in the low SES. And there's a lot of money to be made. There's a huge business case for it.
There's a business case. And so the question that we get, my partner and I, that we get from a lot of potential investors are, well, we like the story, we want to get involved, but there's one thing. Vanessa Mason, cool. That's my partner, and she's whip smart. She teaches me every day.
Cool.
Just a very sharp lady, and I'm very lucky to have her as my partner. But
She's lucky to have you too.
I'm sure she would say that, but I think I'm the luckier one. So I'll give you an example when people say, okay, that's great, we want to get involved, but who pays? People that are low income, we don't how do they pay? They can't, pay for, high-end products, and the answer is they're not paying. Like I mentioned before, it's the institutions that are managing them that are paying, because they are required by law or by something else in order to manage these groups. I'll give you an example.
Yes.
It's kind of a semi-health example. There's a company that Capor Capital invested in the early days called Benestream, and they help they help people get onto Medicaid if they qualify, right? So they just streamline the process. It's very, very easy. Now, Walmart, I think some years ago, changed their policy to where many of their workers in their stores didn't qualify for health insurance because they didn't work enough hours. And so obviously that was a really bad situation. We wish Walmart would have just paid for their health insurance or care. But if that was the way that they were going to form their policy, then Benestream had a solution. And so Walmart ended up contracting with Benestream in order to provide health insurance through Medicare to their employees through Benestream. So they would give them their package. They would say, like, we don't have employer-supported health insurance, but we're going to connect you with Benestream. And so Walmart paid Benestream for that service, right? And then Walmart, I mean, I know thousands of entrepreneurs that would want a Walmart account, right? I mean, that's a great client to have if you're building a new business. And so
then Walmart will pay Benestream, and Benestream will connect those employees to Medicare?
Exactly.
Huh. Okay.
Exactly.
And that streamlines the process for Walmart, and Walmart's not already providing
So
it.
Walmart doesn't feel as bad that they're not providing health insurance for them because they know that their employees have an option. But
Okay.
But yeah, and then these employees can get government insurance, government issued insurance. Now, why is that? Why do you need a service like that? There are a lot of people that qualify for Medicare and even Medicaid that don't connect with it for one reason or another, because the process is too cumbersome, because they're uneducated or can't access, I don't know, a computer or something just very trivial to connect to those services.
It's
right?
not easy enough?
It is definitely not easy. Anyone tells you that Medicare or Medicaid is easy is lying straight through their teeth. It's a very complicated service. It's a very complicated program. I mean,
Anything
we're glad that we
streamlines
have it
is great.
anything. And that's really what tech does best, right? What tech does best is that it makes things faster and it makes things more accessible. If you look at any tech solution out there, they do those two things. And so when we're talking about public health tech, we're talking about the vertical that P2 Health Ventures invests in. The conceptual part of the technology is actually not new. It's been around for many, many years, which is a good thing, right? Because you want a solution to be built off of years and years of evidence, years and years of programming practice. And that's what these entrepreneurs do. What they do differently is that they make it faster and they make it
More
easier
accessible.
to access.
Is this one of the companies in the deck that you highlight?
So we have several, yeah. So if you go back to, this is a good one. So I'll highlight Almada. I won't do everything just in the interest of time, but Almada is a very great example. They're an example of a much more mature company. Obviously, they were around before we even started the fund, so they're not in our portfolio. We wish, but we have worked with them in the past. They're a great company, and what they did is that they took the diabetes prevention program. It's a very famous program, a 10-year longitudinal study on diabetes prevention.
What was that? What did they do to prevent diabetes in that program?
So it was a number. So what they found at the end of the study, it was an NIH-sponsored study. What they found at the end of the program is that if you did these, I think it's like 6 or 7 things, lose 7% of your body mass, change your diet, exercise. I think it was like 3 times a day for 3 times a week, for 30 minutes. Then, don't quote me on that. It's been a while since I've seen it, but if you did these things, then there was a high chance that you would not develop diabetes for pre-diabetics. So it was
Seems
a
like
study
pretty common
for
sense.
pre-diabetics.
Yeah.
It's common sense, right? But now that there's evidence, a 10-year study on it, that's compelling.
Yeah. It's so weird that people need to have a longitudinal study to know that a little bit of exercise and healthy eating will help them lose weight and therefore not onset diabetes.
Exactly. Things that are common sense, we don't really. There they are. We don't really.
So they're a digital behavior change program.
So they're a digital therapeutics company.
Yeah.
So what they did, just to finish the story, what they did is that they took that study and they digitized it. So they created a platform for it. There's an accompanying app. There's a wearable associated with their program. I think they also have like case management workers.
So it helps you get there.
It helps streamline the process. So it helps it makes the process faster
And more accessible.
Right?
Yeah.
And so now the providers, the doctors, can access that data online.
Yeah.
The time that it takes to communicate or to get that real-time feedback is a lot quicker. That's what they did. And they're very successful at it.
And there's our 15-minute timer. Thank you, Ron. Boo, here we go. I was just thinking about the Snapchat streaks. There's like those daily streaks on Snapchat the day that you talk to people.
Yeah.
And I was like, why aren't there like, Almada has, your daily streak with checking in for your healthy eating and checking in for your exercising for people that want to use something like that.
Yeah.
So this is good. So these are good examples. Maybe we talk about, we kind of did a little bit of that. Spending. So obviously, like you talked about, the opportunity is massive for the amount of people that don't actually have adequate accessible access, as well as technology. Making
and when
the
I
process
talk
better.
about the opportunity, if you go back to those 2 opportunity slides, just to quantify them for folks.
Let's do it.
Is there before this?
Okay.
So this is the opportunity I'm talking about. So if you're talking about the value of preventative services, by 2020, this is an almost $145 billion market. There is money to be had in this. Now, secondly, how many people are affected in this group that we're talking about? Now, this is just
U.S.
a person, U.S.
Yeah.
And people with just adults with just one chronic disease risk factor, but we know typically they have more. Many people have more. We're talking about 114 million people and growing, and that's just chronic disease. Think about everything else that comes with vulnerable populations. You're talking about more infections at a higher frequency. You're talking about readmissions. You're talking about noncompliance to medication. You're talking about a lot of things. This is just one small area. I mean, it's not that small. It's not small at all, but it's one part of the opportunity. So it's a huge opportunity. But I think one thing I do want to mention is why did we create a fund around this? Why do we care about this? And it's because of the way that our health system is moving towards. And so right now we are in a fee-for-service health
versus
model.
value-based care.
And we're moving into a value-based care model. And so for those watching, a fee-for-service essentially means if I treat a broken arm, I'm going to treat you for every single thing that I used to treat you with, as opposed to I'm the payer, or there's a payer who pays me, the provider, to treat your broken arm, and they say, I'm going to give you $100, fix the arm. If you can do it with $25, fine. If you use all 100, fine. Doesn't matter to us, but you have $100. And so if I can treat that broken arm for $25, I can keep the cost savings, maintaining a level of care, right?
Yeah.
You have to maintain a standard of care, but if you can do it for cheaper.
So it's an incentive program.
It's hugely incentivized that way. And so the business models that have come out of that, like accountable care organizations, bundled payments, hospital value-based purchasing, and now even more recently, if any readmission under 30 days gets fined, the hospital gets fined if they have a certain amount of readmissions under 30 days.
That's
a year.
These types of incentive structures are very interesting because it's decreasing the amount of corruption in the healthcare system as well.
Oh, absolutely. It's a pervasive incentive system, the fee-for-service model, super pervasive. It essentially rewards sickness.
Yeah, it rewards sickness,
And so with the value-based care model, we're rewarding healthy outcomes. So when we're talking about social determinants and everything, what exactly is going to help providers keep their patients healthy and out of their office so they can reap those savings? It's social determinants of health.
There's got to be some carrots and some sticks at the same time. So like the stick example would be like if you have more than the 30% of patients are readmitted after a month, then there's a stick, there's a punishment, there's a fee. But then the carrot is if you have less than 30% readmissions, then we'll give you a reward.
Yep.
And so
now folks are going to be looking for ways to manage patients better, to have better health outcomes, to keep them out of their office, so they're not having to treat them and spend more and more money. The way we do that's with social determinants of health. We create solutions to help people take care of themselves outside of the physician's office, outside of the hospital. And so this is where my partner and I focus when it comes to tech services.
So the idea is that the public health tech can analyze social determinants and then help people within an ecosystem of their social determinants to assist with value-based care.
Absolutely. So the technology that's coming out of this side is going to be distributed, administered, or advocated by the folks operating here, because they're taking advantage of this new incentive model.
Yeah, yeah.
Right? So that's
great.
This is the thought process that we had. We worked backwards this way.
Yeah.
And my partner and I, both being public health professionals that moved into tech, understand this space very well and can make those connections. Now we're talking about blockchains on the scene now, right?
Good. I'm glad we're talking about this at the time. Good. Yeah, I want to make sure we touch on this.
So here comes blockchain. Enter blockchain. Blockchain has some real potential to address a lot of the pain points that we see everywhere here, actually, right? And so what does blockchain do? What is blockchain? Blockchain is it's an immutable audit trail. It's an audit trail you cannot change, right, at its basic level.
And decentralized.
And decentralized, and you can also write in smart contracts sometimes, right? So a lot of the health service model, much of the fee-for-service, actually a lot of value-based care as well, is a lot of checking and verifying. Checking and verifying that you say who you are, and that you are eligible to get these services. We hire a lot of people in this country to do just that. So blockchain with smart contracts built in, now we can start automating that. It can happen extremely fast. It can take out the middleman. I mean, it can essentially take out a lot of middlemen, banks, potentially even insurance plans, if we're thinking abstractly enough, or I should say not insurance plans, but managed care groups. So that's some of like the easiest use cases for blockchains. Supply chains are another one, right? That is completely based on an audit trail. That's another use case. But we're really excited about what it could do for social determinants of health. One of the things that's very hard to do right now is to track vulnerable populations.
Totally.
Because they pop up here in a community health center, they pop up in this hospital some months later, they pop up there, and then they're accessing a whole set of community benefits that folks like hospitals and the Kaisers and the Aetnas have no access to or can't even find, and it's very siloed and it's very difficult to get. And so, with identifiers, like let's say biometric identifiers, now we can start tracking on the blockchain where these folks are seeking services, how they're living. I just heard, just came across a new company, my partner told me about it just yesterday, that's going to be, they're going to be attempting to use blockchain to track homeless people. So they're like how they're living,
Totally.
where are they meeting them, what do they have on them, what are they, all these, these are all things that we need data on.
So it's everything about the social determinants. So it's like who you are, who your identity is, and then it's all of the different determinants around you and within you, both your biometrics as well as where you're visiting, what health institutions you're visiting, and then it's so not only keeping that on a distributed digital ledger, but then furthermore making it easily accessible for other public health institutions to access that digital ledger, pull your data when they need for being able to see how they can best have value-based care around you, checking in on your biometrics, checking in on your health in general, and then providing some sort of even like incentive structure around value-based care, both for you with something like Almada Health, but also for them with something like incentive structures so that they keep you in good health as well. So it's like the perfect addition to the healthcare industry to make everything a little bit more both decentralized but also immutable. Yeah.
Exactly, and The cultural, political, and social aspects of health is where money leaks out of the health system. So imagine if we could tighten up those holes and keep a lot of those dollars. You're talking about reducing the spend, which is massive in healthcare. You're talking about really making this value-based care system highly incentivized, not only profitable, but outcome generating, positive outcome generating. And blockchains just are a very great solution for that, just because of its decentralization and immutability.
Yep.
Absolutely.
I feel like all these holes, like you said, that exist in the healthcare fabric are about to be slowly sewn up and
we're trying.
Augmented.
It is not easy.
Yeah.
I think, at least when I talk about it, I try to connect the dots for people.
Yeah.
Because I really want them to have that aha moment.
You've been doing a lot of dot connecting, a lot of aha moments. Yeah, it's been fun.
It's my job.
Yeah.
We're trying to get more investment and more innovation happening in this space. But let's be realistic. Like, it's not easy. Healthcare is a very, very hard ship to move. But it is not impossible. And what I will say, and maybe even what I will end with, is that when a solution takes hold in this market, it stays forever. Unlike other
if there's
tech
enough
verticals,
demand
right?
for it, if it's actually a good one, yeah.
That's how our regulatory process and how our health system works. Think about policies that have been implemented or standards of practice that have been implemented that haven't changed. So, for example, checking for prostate cancer only recently has gotten an overhaul, and I think we started that decades ago. When things prove to work in healthcare, they stick around.
They stick around, yeah,
for a while.
And so I like how a lot of your work has to do with inclusive health. I think that's like the essence of your work, and making sure that people actually see that there's a whole huge amount of business model also that exists in public health for even low to medium socioeconomic status groups, as well as just sewing up those holes in the fabric that exist, especially for low SES.
Yeah.
Moving forward, it's going to be. I'm glad that you have. So P2 Health has a fund that invests into these companies.
Yes. We started Fund 1. We started with building the ecosystem.
What's the size of the fund?
So the target is 15 million.
And have you raised a couple
So
of it
we
yet?
have started raising.
Okay.
And my partner and I are nose down working on that.
Good.
Blockchain, we've incorporated blockchain to the technologies we're evaluating now, and so that's
Good.
been really, really exciting. We started off as a meetup, believe it or not.
Oh, that's great.
Yeah, we started off as a meetup.
And now a fund. I love it.
And that's how it grows, right? It goes
Yeah.
from a meetup, it blows up into more people than you could ever imagine. That turns into a community. That community has needs. They want to build things. They want to invest in things. They want to work on things. And that then becomes an ecosystem if it gets large enough and distributed enough. So we have a small team in Atlanta right now.
Good.
Flying
Hell
out
yeah.
there tomorrow to meet up with them.
Good.
And then from that, you start to figure out where the greatest need is. And so after thinking a lot through it, Vanessa and I decided that the biggest bottleneck was going to be access to funding. So decided to raise a fund.
So let's get you guys funded and get you invested into these companies.
We would
let's
love
do
that.
it.
Anyone that's interested in any part of P2 Health Ventures or in blockchain health, we're at p2health.co. It's VC now, but it'll reroute. And I'm Marquesa at p2health.co.
Whew. Awesome. All right, we have a couple simulation questions to run you through at the very end.
Okay.
All right, so our first simulation question that we like to ask is, what is the most beautiful thing in the world?
Whoa. What is the most beautiful thing in the world? The most beautiful thing in the world is seeing the joy and the inspiration that you get from seeing the joy in someone that you love. I think that is going to be my answer for today. I have a new niece. She's only 7 months.
There you go.
And so she's got me thinking a lot about that question.
Yeah.
And I think it changes throughout your life too, what that means to you.
Yes, yes.
And so when she was born, just watching her grow up and just watching her just be super happy and so innocent and just like the smallest things she gets a lot of joy out of.
Just yesterday with Rack, we were talking about how the aperture for their happiness and joy and purpose and like their absorption of this great signal of the cosmos is just so open.
Yeah.
And then like
Yeah.
over time, sometimes society closes that aperture.
Yes.
Yeah. So
Yeah.
so there's these like periods of opening.
It
and
is.
closing.
It is, and I've definitely experienced that. Yeah. So at the moment right now, and throughout my life, I've experienced this. But you know, seeing someone that you love be happy,
Hell
and
yeah.
then kind of absorbing that energy and let it
So
affect
great,
you.
yeah, when they're like just ecstatic
Yeah,
and you're just like,
yeah.
oh my God, I'm feeling you, it feels so good.
Yeah.
Yeah.
And so when someone says, I'm happy when you're happy, I mean, that's not cliche, that's real. I
Yeah,
think that stems
exactly.
from somewhere real,
Yeah,
right?
and there's
Yeah.
some mirror neuron action going on, like mirror feelings, you know, mirror touch that's happening.
Absolutely.
Yeah.
Yeah,
Even
yeah.
when you smile, I smile, you know?
Oh,
Yeah,
great.
Yeah.
There you go. See, it's working everywhere.
Yeah, it does, it does. All right, how about next question is, do you think we're alone in the cosmos?
No, hell no. No. No, and I really want to meet one of them before I die. Can we hurry up? Because look, I mean, right?
I want to meet some of them before I die. Can we hurry up?
Wouldn't Facebook love that? Forget 6 billion people on Earth. We're talking about 300 billion people.
Yeah, we got to go connect to the other ones.
I really want to meet some
Me too, yeah, us
other
too.
being.
Yeah, yeah.
Well, that's
Yeah,
the thing.
I know.
See, I'm not at liberty to talk too much about this, but
We don't exactly know how benign the civilization's going to be that we encounter.
I'm hopeful.
I'm hopeful that there are brothers and sisters. Let's see if we can get there.
Yeah.
All right. And how about our last question, which is, do you think that we're in a computer simulation? What do you think about that?
Oh, God.
Look at all the Marquesas.
Oh, my goodness. Well, they say ignorance is bliss. So if we are, and I am definitely borrowing that from the Matrix, I choose ignorance. Sorry.
You blue pill?
Yeah.
Don't blue pill. Don't do it. Don't do it. Red pill with us.
the thing is with the red pill, once you eat the red pill, you'll want
The
blue
blue
pill.
pill, right.
So I'm with our guest on this one.
Blue, I'm sorry.
Okay, so you think we are or are not? Just ignorance is bliss is your answer?
I don't think we are.
You think this is base reality?
I do think so, yeah.
Okay.
Yeah.
Okay.
I'm still going with the blue pill, though, even if it is.
Go Warriors.
Oh, yeah, let's get to some sports. All right. Thank you so much for coming on the
Thank
show.
you for having
This
me.
has been such a pleasure.
This was
We
a lot of fun.
Really appreciate it. I'm glad you had fun.
Absolutely.
Good. Let's get more people talking about public health and inclusive public health.
Please.
And public health tech.
Yes.
Yes.
Yeah, we need lots of great innovators, and we need lots of great investors, and lots of good buyers too. But
Yes.
yeah, ultimately, I think it really is going to change the fabric about how we live.
Exactly. And a little bit of blockchain sprinkle on top.
Like blockchain bay, sprinkle it.
All right. Thank you, everyone, for tuning in. We greatly appreciate it. If you guys had a good time, make sure to subscribe, join the family, write your comments below. Would love to hear from you. We'll feature you on our Instagram and our Twitter. Please do comment below, give us a like, share the content with other people. We always say this, but go create with this content. Go do something in public health with it. Either write about it, make a video about it, go and build a company in the field. So go create. Don't just consume here. Go create. And join us on Patreon. We need to make this sustainable. We need to continue growing this project and impacting more people with it. So do join us there. Thank you, everyone, for tuning in, and we'll catch you soon. Thanks, Ron Vargas. Peace.